little things. So, oh, here we go. Yeah, so I was one of the 14 recipients of the CIHR Leadership Award and the only Saskatchewan recipient. So yeah, and a huge thank you to SCPOR. Couldn't have done or achieved that without their support. And in terms of that application process, I'm really happy to talk about that, especially with any newer researchers, who are wanting to get into this work a little bit. I'm not sure if CIHR will be offering the award again, but I really hope they do. So it's really excellent. So on the screen there, you'll just see a little bit about, kind of what I had to do for the application. There were some additional documents that I had to include as well. And the project that I had proposed relates to service dogs. So I have been working with Dr. Colleen Dell since about 2018, and we've been looking at various aspects of the role that service dogs can play in the lives of Canadian veterans. And these are veterans who have various operational stress injuries, including PTSD, sometimes have traumatic brain injuries as well, or physical mobility limitations. And so that's been my general area of research, and that is what I proposed for this larger project. And in particular, there were 3 studies that I have been conducting and developing at this point, because I've been doing this project since, I guess it would have started in September 2020. So just over a year now. So if you have questions about the research, and want to know a little bit more about veterans and service dogs, happy to talk about that too. But what I want to really focus on are, when we think about conducting patient-oriented research, there's tons of literature out there that tells us the ways that, we need to consider doing it. And definitely there's some ideas about the better ways or better strategies to employ, and things that are more, considered essential for it to be patient-oriented research. And so, in my proposal, I had to make sure that many and if not most of those components were included in the project itself. So on the screen here, I've just kind of summarized some of those components, but if you look at the Portlet tool, I mean, that is a really great guideline as well, in addition to a lot of the great research or literature that's out there on how to do POR. But these were some of the components that I included. And the biggest feature for me was having a research advisory committee. And so having a research advisory committee, it is wonderful. I absolutely love that I've been able to bring together people who, know more than I do about, frankly, about certain topics, because as much as I know about how to conduct research, I don't have lived experience with PTSD. I have some experience working with service dogs. I've been really fortunate to participate in some training options, but I've not had my own. I don't have PTSD, and I don't run a service dog organization, and I don't know people, I don't have loved ones with PTSD either. So there's a big gap in my knowledge, and that's why I love being able to work with other people who bring forward that lived experience, or bring that research background, or bring that topic, subject area expertise, and it's just, for me, I think about it in terms of, we're better together. But in bringing people together, especially, depending on the topic area that you're, conducting research in, sometimes it doesn't go smoothly or as smoothly as you might hope. So some of the challenging features that I've encountered so far with my research advisory committee are summarized on this slide here for you. But, and I've kind of spoken about, I'm working with individuals that are, in many ways injured. And so working with people who have post-traumatic stress symptoms, or who have depression, or have, traumatic brain injuries, there are limitations, especially with their concentration and their memory. Mood swings as well can be a big part of it. So there's a lot that I need to do in order to ensure that I can work effectively with my patient partners and with my committee members as well. So compassion. Honestly, compassion goes such a long way, and being humble and being open to learning. The other thing that I've noticed too is that, you know, within my committee, there's some history, and there are some contentious relationships, you know, that are going on. So I, you know, have to be aware of that, and I have to understand that history and respect that history, because it's not necessarily just going to magically get better because they're all on my committee together. I've also had instances where it seems like people are very interested in being a part of my research, but they don't really want to participate as much as I might have thought. And so I've been trying, you know, to, you know, be creative and, you know, find different ways for them to engage and make sure that I know their preferences for engagement, like right from the very beginning. But I've had some people, you know, they just really don't get back to me. And I just, again, I have to respect that. I don't want to be a nag, but I also have to question whether or not they're on my committee for the right reasons. So some people just want to be able to say that they're a part of something, and that's fine. It's not really hurting me in the end, but, you know, in terms of, again, trying to enact POR in the way that I would like to, sometimes it's, you know, again, there's not, you might be able to do everything that you think is going to work in terms of getting them to engage, but at the end of the day, you cannot force people to get involved with that if they don't want to. The other thing too has been getting feedback. So I have some people on my committee who are just frankly quite blunt, and they will just say, instead of softening things, they'll just say, oh yeah, that's bad. So I have to, again, not take things personally. I have to stay humble, try to understand where they're coming from. I think a lot of them are just trying to be efficient. A lot of them do care about the work and the research, so they just want it to be as good as possible. But yeah, sometimes they don't really yeah, soften their feedback to me. And so again, tons of different, you know, examples of that I could talk about, and just for the sake of time, I won't go through all of them, but I would say that generally the mitigation strategies, you know, that I've been able to use so far, you know, have really served me well, because the project is moving forward. Thankfully, I've not had anybody leave my committee. I do see more people engaging. I see them getting excited about it. I respect that, you know, they've got things going on too. They have, you know, busy lives and other competing interests. So I can't be the priority. It's not their full-time job, it's my full-time job as well. But I do want to make sure that I'm always moving forward and always getting creative and always finding those ways to make sure that their engagement with the whole project is as fulfilling as it can be for them. And so that, you know, my project can be greatly informed by what they're doing as well. So yeah, some of the strategies, again, I'm so thankful to have a really great team around me who have experienced similar things as I have before. So turning to them, you know, consulting with my mentors has been so instrumental for that. Consulting the literature as well has also been really helpful. You know, probably one of the biggest things I could do is not fuel gossip, especially with those contentious relationships and those long histories, you know, between some of my members. And this might seem a little, you know, out there, but because I think a lot of times we think about committees as coming together and meeting in, you know, in not in person right now, but at least meeting over Zoom or something. To date, I have not had one group meeting. And so I solely have one-on-one meetings. I take the time to meet with everybody, however long they want to meet. Sometimes I'm on the phone with people for 2 hours or more. And that's fine, because I don't want to force people together that don't get along. And especially, I just don't, you know, this is a volunteer position for them. I don't want them to feel that pressure. So again, I've given options. I've given options for people to meet together, and they've all chosen to just do one-on-one. So giving that option has been really, really excellent. So yeah, if anybody has questions about some of these strategies, and again, if you want more examples, happy to provide. They've been plentiful, that's for sure. But honestly, above all else, the biggest tool in my toolbox right now is just having, you know, critical thinking skills, right? So not just blindly following what the literature tells me to do with patient-oriented research, not just following and, to a T what the Portlet tool tells me to do or try to achieve. I do use those. I want those to be a guide, but I'm also living within a realistic situation where I can't necessarily make it happen exactly as it's said to do so. So I do have to be very, careful about how I enact those different elements of POR within my project. And again, just be open-minded and humble and compassionate. These skills go so far. And I think we often can take them for granted. So those are all of my main points for this presentation. Again, I wanted this to be just something to, open your mind a little bit, consider another perspective, keep in mind that you're not alone. If you're struggling with, enacting some of those elements of POR, you're definitely in good company. There's lots of us who have those experiences as well. So I do want to thank everybody that is, making my project possible, including my supervisor, my research advisory committee members, my team. If you want to learn more about the project, you can go to servicedogresearch.ca or you can hit me up by email. Thanks so much, everyone.
Thank you, Lindsay. I would love to have questions either in the Feedloop chat box or if you want to raise your hands, that would be wonderful as well. Just to sort of get started on a few discussion points. Lindsay, I first want to apologize because I know that I wrongly used the word therapy dog synonymously with service dogs. And I'm just wondering if you would take this opportunity to just explain to us the difference between a service dog and a therapy dog.
Oh, for sure. It's a very common question. So overall, I would say that therapy dogs and service dogs, they both fit under what I might consider an animal assisted intervention. They're also working dogs. So there's lots of umbrella terms that they're both encompassed within. But a therapy dog traditionally works with a clinician or a therapist, and they will aid that individual in therapeutic interactions. So they often will help with rapport building or helping with the therapeutic bond. There are other types of therapy animals that are more so-called wellness animals, and those are what we would see with our the USAS Pause Your Stress program. So that works in conjunction with St. John Ambulance. They use the term therapy dogs. It's not quite what they do because they're not clinicians, they're not therapists, they are just volunteers. Some of them might have that clinical background or that therapeutic background, but it's not necessary. You really just need to have a dog who loves people. So you want that dog who wants to be pet, who wants to play, who wants to interact with humans. So those are therapy dogs. Service dogs, there's a number of different ones. The more classic one would be guide dogs for people who need them with their, to help with their sight or any other mobility types issues. There's also psychiatric service dogs. So those are the ones that work with the veterans that I'm working with. And those dogs are trained very specifically to work with one person and to provide various sources of support. So you can actually train those dogs to help people with their symptoms. So for example, for the veterans that I work with, you can teach those dogs how to wake them up from nightmares or to interrupt them when they're having a flashback, or they just provide a lot of general comfort and support, especially if a veteran is feeling anxious or hypervigilant. The dog can be, trained, and the veteran can be trained as well to turn to that dog in those times.
Thank you, Lindsay. That is really helpful. I think that does really clarify the difference for me anyways. I also wanted you if you could just talk a little bit more about this idea of consulting with a mentor when it comes to POR, because I think one of the things that we see more and more when we're working with research teams is that need to consult others. And I'm just wondering, how did you go about finding a mentor, and how did, and what role did they really play in coming alongside you with your research?
Oh, it's such a great question. And I'd say that my journey to finding a mentor is not conventional. So my mentor right now is Dr. Colleen Dell. And Colleen and I actually started working together. It would have been in 2017 or 2018 when I was at the end of my PhD studies, and I was on funding. I was a SCPOR trainee, and I originally had another project, and it didn't work. It fell apart, and I no longer had a potential mentor through that project. And so I think Christine, you and maybe some other people from SCPOR had put out a call, and Colleen answered the call. So honestly, like I'm a huge believer in fate. Things just work out sometimes, especially, you have one plan in place and then something else completely happens. So yeah, so that's kind of how I got hooked up with Colleen. And she is, she has tons of experience working with community-based research projects, and now she's kind of moving in more into the patient-oriented realm as well. And so her long-standing experience, she's got probably 10 to 15 years now of doing community-based work and working directly with the patient partners for the various studies that we have going on. And so it's not even just her, because she surrounds herself with people who have that experience as well. So even if she doesn't necessarily have, the answers or hasn't had that direct experience with a particular issue, then she tells me, oh, you really need to speak with this person. So it's not just the one mentor, it's really that team around her and that I'm now surrounded with as well. That makes such a huge difference. And feeling like, oh, okay, so I'm not the first person to experience this, and I won't be the last. So I think having that sounding board can really just, again, help you not waste time, I would say. I think it makes it much more efficient to just go and talk to somebody who's lived it.
Yeah, I think just the value of a network there, right? And it's wonderful. Just a plug for all the, for the ARA, our affiliate research group, which sort of tries to provide that network and support other poor researchers. And you can find more about that on our SCPOR website. But yeah, just great to hear that is actually a really good strategy when doing patient-oriented research. I think our time is just about up, and I think we're ready for our next group to present. But thank you, Lindsay. It was great to hear about, the essentials and the realities, and just how we have to ensure that we're sensitive and compassionate when we engage with our patient partners.
Mm-hmm. Thanks so much, Christine.
I'd like to introduce our next speakers at this time, and that is Dr. Hazel Williams Roberts and Fiona Fick. Hazel has a PhD from the University of Saskatchewan, a Master's of Science from the University of Aberdeen in Scotland, and a Bachelor of Medicine from the University of the West Indies. Hazel joined the SHA research team in 2019, and her research specialties include applied research in community and population health and mixed methodology designs. Fiona has a Master's of Arts in Applied Social Psychology and a Bachelor of Arts honors degree in psychology, and those are both from the University of Saskatchewan. Fiona also joined the SHA research team in 2019, and her research specialties include program evaluation, realist evaluation, and qualitative research. Hazel and Fiona will be providing a summary of their evaluation of virtual care in youth mental health and addiction services in Saskatoon. And once again, a reminder to submit questions to the chat feature in the platform. And again, over to both of you.
Pleasant good morning to all, and thank you so much for the opportunity to share the findings of an evaluation that was conducted of virtual care in youth mental health and addiction services earlier this year. Please allow me to adopt the protocol that's been established to acknowledge the original keepers of the land, as well as to renew our commitment to working in the spirit of truth and reconciliation. Today, Fiona and I will be making the presentation, but I must acknowledge the contribution of so many others who are integral to this project. So I must mention our colleague, Maeve McLean, who was a third member of the evaluation team. But for this project, we also had a project advisory committee that provided stellar guidance really through all phases of the project, from the project development to the knowledge translation. We wouldn't have been able to do this work without the youth clients and families and the clinicians who graciously shared their stories with us. And I must also acknowledge that the study was funded through a Virtual Innovations in Care grant, a VIC grant that came from framing. Youth mental health and addiction services offers team-based integrated care to address mental health and substance use problems using a variety of formats, so individual, family, and group formats. Additionally, youth outreach staff provide crisis intervention and support to youths who are marginalized, often racialized, and facing difficult life circumstances. So in April of 2020, the Youth Mental Health and Addiction Department pivoted very quickly to offer virtual care in order to minimize any disruption to services, as well as, of course, to limit direct contact as part of the pandemic response. Because of the rapid transition to virtual delivery, as well as the limited experiences of clinicians, really with virtual delivery, there was a poor understanding of how exactly, to optimize virtual care for this population. As a new initiative, it was pretty important to the department to understand, what was working well and identify areas for improvement. And so an evaluation was commissioned to learn about the experiences of youth and families and clinicians with the implementation of virtual care. So as I said before, the aims of our evaluation really were to understand the experiences of clients and families and clinicians, including the benefits and challenges of virtual mental health care. We also wanted to identify opportunities for improvement and, of course, to provide recommendations for future implementation of virtual youth mental health and addiction care. In this project, there was an explicit expectation for participatory co-production of knowledge. And so, the project advisory committee really was an integral part of this project, from the development of the proposal to, how we would translate the knowledge that was generated and the kinds of knowledge translation products that would arise from the study. In this evaluation, we employed a mixed method research strategy that integrated clinician interviews with focus group discussions in youth and families. And we also did an online client survey. So in our project, qualitative inquiry really was the dominant focus. And the themes that arose in the first phase of the project were used to inform the survey. The survey was then distributed to all clients that was on the active case list. In terms of our approach to the interpretation of the findings, we look for similarities and differences across the sources of information as well as the methods. And we drew inferences about the likely mechanisms that result on the different circumstances. So I'll now turn over to Fiona to present the results.
Thanks, Hazel. So with limited time, this will be a very quick run through of the results, but we do have a full report if anybody is interested in hearing more about it. So as Hazel said, we did a survey and interview and focus groups. And for a bit of background, survey participants were 60% female and mostly between the ages of 13 to 18. 12% were First Nations and 11% were Métis. And most participants had had a number of virtual visits, so they were able to speak to it. Only 6% had one visit. Next slide. So for a bit of background as well about our clients, participants were mostly experiencing anxiety and depression, although it is a bit alarming to see here that 43% were self-harming and 40% had suicidal ideation. Next slide. So telephone and texting were the most convenient ways to communicate with counselors. Not many people had used the official platform of Facebook, and those who had used it found it to be glitchy and laggy. People generally preferred a platform with video options as they like to see other people's facial expression. So although most people preferred in-person care, many clients did say that they would like to have the option of virtual care available if they needed it. Next slide. Benefits of virtual care included easy access to care with less travel time and less disruption to the day. Appointments were seen as more flexible and were sometimes easier to keep. Some youth also felt more comfortable being in their own space without having the pressure of in-person communication. And both clients and clinicians felt that it was helpful for counselors to literally be able to see into their client's life through the camera and to understand their client's experiences. Next slide. Some challenges to virtual care included lack of privacy in the home, which was hard, especially if you're trying to talk about family issues. Greater distractions with things like video games, feeling that you could avoid virtual appointments or ignore what the counselor was saying, or some clients said it was easier to divert attention away from issues that they didn't really want to discuss. Some youth also felt that virtual care had sometimes even contributed to the feeling of being alone and cut off from other people, or that counselors didn't really understand the severity of their situation with virtual care. Next slide. Some clients also felt that it was difficult to create a trusting relationship with their counselor when they had not met together in person and weren't able to see facial expressions and body language. However, clients also said that it depended on the counselor, often, as some counselors were more skilled at creating virtual relationships than others. On the flip side, a couple of people felt better with having more anonymity when meeting virtually, with one person using the analogy of having an avatar. And I think this shows that one size never fits all, and so care delivery methods always need to be client-centered. Next slide. So when asked for an overall rating of virtual care experiences, 60% of people felt that it was good or very good, and 51% of people felt that it was not as effective as in-person care. Next slide. So because I have a realist background, we wanted to create a program theory, but virtual care delivery is part of the Youth Mental Health Addiction Services program and not a program in and of itself, which of course makes it a bit more difficult to create a program theory. So we created a series of if, then, because statements, just to summarize different aspects of the context around virtual care, the underlying mechanisms that lead to successful or less successful virtual care, and the outcomes arising from each scenario. And we condense them to create these graphics here that are helpful in pinpointing issues that underpin success, as well as those that require further attention. This is a summary, but the full version is in the report. So here we can see that virtual care works well when the context is that virtual care provides face-to-face interaction. It is seen to be convenient and easy to access, and clients feel that they have a safe and private space. The mechanisms are that clients feel comfortable in their space and that the counselor is available when needed. So clients and counselors bond and establish a trusting relationship, leading to outcomes where clients are able to speak freely. The therapeutic bond is strengthened, leading to better client outcomes. Next slide. But sometimes virtual care does not work well. And so the context that we see here is that there are distractions and lack of privacy. There's an existing feeling of isolation and no body language cues to work off. The mechanisms are that there is low client engagement with the session. Clients feel that they can't express their feelings. Feelings of isolation are exacerbated, and there is no trusting relationship. And this leads to outcomes where counselors do not understand their client needs. There is a poor therapeutic relationship and poor client outcomes. And I'll hand it back to Hazel to continue on with the recommendations.
As I said earlier, one of the objectives of the evaluation really was to identify, areas for improvement and to provide recommendations. And so the project advisory committee kind of distilled the findings and offered this guidance. Now we know that virtual care works well when it's clinically appropriate, when it was the client's preferred option, and when clients and clinicians really have an appropriate platform that was conducive to the development of these positive therapeutic experiences. And that provides the basis for us saying that, a client-centered approach is really required to be able to meet the expectations and preferences of clients. You heard about some of the struggles that the clients had with using some platforms, and so the committee advances that a video platform that is easy to use, that doesn't glitch and lag, is really needed to create and maintain those therapeutic relationships. They also felt that offering a variety of formats, for example, email and texting, would allow clients to really use what works best for them. Within the project, it was acknowledged that there was a steep learning curve with respect to virtual delivery when it came to clinicians, and all it increased. It got better with time. Clinicians still require enhanced training in virtual delivery of specific therapeutic approaches. We also acknowledge that it can be quite challenging to establish a relationship virtually. And so, clinicians really ought to prepare clients by having a purposeful discussion at the outset. And of course, be quick to intervene when they recognize that there are difficulties and problems that are occurring. We know that virtual care can increase the inequalities, particularly for persons who are already face multi-level barriers to accessing care. And so the Project Advisory Committee also offers that greater efforts are really needed to accelerate access to virtual care for those who are marginalized, who may benefit from virtual care. We are always transparent, no study is perfect. And so we acknowledge that the following limitations occurred within our study. So while the findings are generally transferable to the local and youth population, they may be less relevant to subgroups. For example, we face a lot of challenges with recruitment of youth from outreach programs. All of our data collection was done virtually because this was happening during the pandemic. So naturally, it might have excluded persons who did not have ready access to technological resources. And although it's the survey instrument is theoretically grounded in that it's connected to the first phase, and it was pre-tested and approved by peers and patient partners, it was not formally tested for validity and reliability. So that is a limitation that we have. If you would like to learn more about the project, we have lots of nice resources, an infographic, a video, and a report, all informed by a wonderful project advisory committee. So we would like to invite you to check that out. That's all that we have today. So we invite any questions.
Thank you so much, Hazel and Fiona. If there's any questions, please put them in the chat box or raise your hand. Thank you so much for that presentation. I do have a few questions. Really interesting work given the COVID situation on a whole. One of the things that I'm interested in is that, whether it was healthcare or education, everybody had to make this really quick pivot to virtual delivery. And I think what we quickly realized is that it isn't an easy transition, and it is a very different model of either teaching or care. And I'm wondering if there's been any way that this has been addressed. Is there any training coming out? Is there any workshops, or what are we doing so that healthcare providers have a bigger toolkit when it comes to actually engaging in virtual care?
It's my understanding, like we made several presentations to healthcare providers as part of our KT strategy, that early on there were some limited opportunities to have training, but the director has assured us that they have identified some other opportunities and that they're going to make them available to the staff. So I don't know if Fiona can remember anything else, but that's kind of what they told us. But they have transitioned a lot to kind of back to in-person, once the situation stabilized.
Yeah, I think we're going to see that there probably is in the future a hybrid approach to this whole sort of question of access to care, and I think you're right. It just becomes a matter of ensuring that it's client-centered. I see there is some questions in the chat box. A question from Dr. Winquest is, can you tell us more about the membership on the project advisory committee?
So this particular project was, I think, unique in that when we were engaged, meaning when I say we, the research department to provide the technical support, the youth mental health and addiction services had already identified the opportunity, like the grant opportunity, and they already had a PFAC that was supporting the programming. So really the components were already in place, for a strong, like patient-oriented approach to this evaluation. So on our advisory committee, there were clinicians, there were representatives from the patient family-centered care, and there were patient partners, as well as kind of the parents, because we had like youth clients as well as parents. So that was mostly the composition of the committee. And then, we comprised the evaluation, like technical team that was translating their requests and their guidance to implement the study.
Thank you, Dr. Williams-Roberts. It's interesting because it really is the voice of all those stakeholders, including the youth themselves. That's terrific. A question also from Susan Petrick. Will you be making suggestions for guidelines in best practice for virtual care and troubleshooting ideas?
Not me personally, but in interacting with the director, I know that she's been connected to the virtual care portfolio, and they've been in discussions, and she has been invited to be represented on their committee with respect to making decisions about what might be the best platforms that would be patient-centered. So I know they are engaged in that way, and I'm confident that this will be translated in practice.
Also, just to say that I did invite the virtual care department to a couple of our presentations, and they came. So they were also interested in the report. So they have heard about this too.
Thank you so much. Yeah, just that whole merit of integrated knowledge translation, where you have all those stakeholders engaged. That makes it so much easier to sort of move that, mobilize that knowledge. I do think that we've come to the end of our question time here, and I thank you once again, Dr. Roberts, and thank you, Fiona, for the presentation. It's great to learn more about your POR team and youth mental health and virtual care. At this time, I'd like to introduce our final speaker, Dr. Sheila Hirani. And Dr. Hirani is an associate professor at the University of Regina, Faculty of Nursing. She is a neonatal and child health nursing professional, a nurse academic, a nurse researcher, and an international board certified lactation consultant. She's actively involved in patient-oriented work surrounding improvement of health equity, health systems, program and policies that often negatively affect the health and well-being of marginalized and vulnerable groups of women and young children in Canada. Her professional goal is to make a difference in the lives of underprivileged children and marginalized women through her research, her leadership, and community services. Today, Dr. Hirani will be sharing her research regarding the challenges, opportunities, and way forward for refugee mothers who are breastfeeding. Once again, a reminder to submit those questions in the chat feature. And I welcome Dr. Hirani and ask you to please go ahead.
Thank you so much for inviting me at this prestigious platform. It's my great pleasure to present my research on breastfeeding practices of refugee mothers in Saskatchewan, challenges, opportunities, and way forward. Thank you so much for the introduction. I'm an associate professor at the University of Regina, Faculty of Nursing, and I acknowledge the land. And University of Regina is situated on Treaty 4 lands with the presence of Treaty 6. I would start with sharing the background on the project that I, along with my team, undertook on the refugee mothers in Saskatchewan. Having the clear picture of how the refugee mothers have been to in their life, like we see a number of situations where they are quite vulnerable and they have been through lots of vulnerability in their lives. Refugee mothers are one of those vulnerable groups who often experience the trauma, family separation, forced migration because they are traveling and migrating from one country to another. And they also having the issues surrounding the social disconnection in a new country, because most of their migration are the forced migration because of the war or natural disaster, and they are moving to a new country where they may not be mentally prepared to move. The vulnerability of the refugee mothers specifically often have a negative impact on their well-being and the breastfeeding practices related to the social, emotional, psychological, and the physical stresses. The challenging transition has to be acknowledged for the refugee mothers because they are arriving in a new country and often present with the language difficulties, inadequate health insurance coverage, lack of access to the healthcare services, inadequate breastfeeding support. Breastfeeding at the time of the migration is really very much recommended by World Health Organization for the survival and for reducing the mortality and the morbidities among the young children. Each year, Canada welcomes many refugee families from different countries who are under the influence of war or facing the natural disaster. And Saskatchewan is one of the growing provinces in Canada that has a noticeable increase in the refugee population who have the young children, especially those that are the infants. Unfortunately, till to date, Saskatchewan has only one healthcare facility that is accredited with the baby-friendly initiative status. And overall, Saskatchewan has very limited number of healthcare facilities that are providing service to the refugee mothers with the young children. There are significant knowledge gaps surrounding the breastfeeding facilitators and the barriers surrounding the breastfeeding practices of the refugee mothers who are accessing and utilizing the healthcare services in Saskatchewan. That indicated that there is a need to explore that what are their experiences in order to better respond to those challenges that they are facing and initiate the need-based and culturally appropriate interventions in order to save their and protect their breastfeeding practices and save lives of their young children. In view of the gap analysis, the aim of our study was to explore the breastfeeding experiences of refugee mothers who are accessing and utilizing the healthcare settings in Saskatchewan, Canada. We undertook the critical ethnographic study, and this was a study design chosen because it fits very well to the situation of the vulnerable group and population that are needing much kind of the advocacy, and there is some change required in the setting while having them involved as one of the patient partners. So we identified from their experiences that what are the challenges and constraints that they are facing towards their breastfeeding practices. We undertook this study in different cities within the province of Saskatchewan. The data was collected using the multiple methods, including the in-depth interviews, observation, and document analysis. The sample included the 27 refugee mothers who were having the child age 1 day to 24 months. And for the in-depth interview, our sample included the mothers from the different cities within Saskatchewan. And they were mainly from Syrian communities and Eritrean and the Somalian mothers. We acknowledge the funding that we received from Jim Pattison Children's Hospital Foundation, and we are very thankful to our collaborators, specifically United Way Saskatchewan Health Authority, Regina Open Door Society, and Saskatoon Open Door Society that provided support in recruitment of our study participants. Now the findings. We came from the refugee mothers' experiences that they are facing the tremendous psychosocial barriers towards their breastfeeding practices. They acknowledge about the lack of social support. They also shared about that there are various sociocultural perceptions and constraints which are not supporting their breastfeeding practices in the host countries. They shared about the economical challenges because most of the time, like during COVID, many refugee families lost their employment, and it was quite difficult to manage both the childcare responsibilities and manage it between the other job and work-related responsibilities that they were having at the same time. Mothers also shared that there are various maternal and child-related barriers that are also negatively affecting their breastfeeding practices. They spoke about various challenges surrounding their labor and delivery experiences, especially in the healthcare setting where they were not knowing English and not many people were knowing their language. And there were not many interpreters available at the same time. Mothers also mentioned that many times they feel shy to breastfeed in public or in hospital or in healthcare setting very openly if there is no privacy. They also shared about that they are facing various physiological challenges and child health related challenges, specifically when they are trying to breastfeed and nobody is there as a social support for them to provide them any kind of help to sustain their breastfeeding practices. Many mothers shared about that they initially face the breast engorgement when they start with some kind of the infections, and most of the time they don't know where to head to for the treatment and how to communicate to the healthcare providers to whom they couldn't communicate in the same language that they speak. They also shared about the various healthcare barriers, specifically mothers who were hospitalized and they were in the hospital for the labor and delivery. They mentioned that most of the time that the food that is offered in hospital in Saskatchewan is not adequate, or maybe they are not in the culturally appropriate food that they are receiving most of the time. They also spoke about the poor quality of the maternal and baby care in the hospital. And specifically, they mentioned that many times they are being offered the formula sample instead of the breastfeeding counseling. And that makes them more confused that whether breastfeeding is good or they should continue the formula milk that's being offered in the hospital as a sample. They also spoke about that many healthcare settings, especially the health clinics, do offer the formula samples as well. They spoke about that there are no interpretation services most of the time available whenever they are accessing and utilizing the healthcare services. They also spoke about the hospital violation of the breastfeeding guidelines, especially offering the formula and not having the breastfeeding counseling done in their own language. They also shared about that most of the time they are facing the challenge of accessing the healthcare settings, specifically in the new country. Whenever they don't have the transportation facilities available, the ambulance services are even very costly. So they are actually facing more of the challenges surrounding accessing the healthcare providers and the healthcare support in general. Mothers also shared that due to COVID, not many nurses and doctors are getting in touch with them because getting to the appointment is quite difficult. And even there is a lack of follow-up care for them. And there were instances when mothers were sick, they were discharged, when they were home, nobody actually followed up on their breastfeeding practices even after the childbirth. Mothers also spoke about the racism in the healthcare setting and the lack of culturally sensitive approach in the healthcare settings that were negatively affecting their breastfeeding practices. Mothers also spoke about various environmental barriers. They spoke about that COVID has really increased their stress, anxiety. They are not able to function as before because many of them, as I mentioned, lost the job. They also spoke about that being in a new country, specifically coping with winter, with no proper housing or no proper transportation services, even make it quite difficult for them. And even their previous exposure to war and displacement has really affected negatively their mental health. So based on the findings of our study, there are various recommendations that we put forward in general. Our first recommendation is that it is quite essential to involve refugee mothers and their family members as a partner whenever there is a designing of the innovative or need-based programs that are designed to promote, protect, and support the breastfeeding practices of mothers. Many times there are various programs that are developed, various policies are being developed, but those clientele who are the vulnerable group, how much we are really involving them into that development is very, very essential. We also recommended that the breastfeeding practices of refugee mothers can be promoted through healthcare support, culturally appropriate services, interpretation services in the hospital care settings and in all healthcare settings in general, implementation of the baby-friendly, breastfeeding-friendly initiatives, community and hospital-based breastfeeding campaigns, and the follow-up services. We also put forward the recommendation that social media helplines, telehealth should be used, and as much as possible, mothers should be offered the need-based breastfeeding counseling in their preferred language so that they can communicate more openly and they can share their concerns very openly with the healthcare providers and get the required support from them in order to take care of their better needs, as well as their mental health needs, their breastfeeding needs, and assure that their child health is taken care of. We also recommend that there is a need of the partnership and the collaborative efforts by the interdisciplinary professionals, governmental and the non-governmental organization in order to extend the social support, facilitate the resilience, promote the health, build the capacity of the refugee mothers who are with the young children in our province. Just to summarize the key findings of our study, our team have developed a knowledge translation video that I would like to play. And I hope that this gonna be a better summary information and link gonna be available as well for further reading.
This video presents the challenges and breastfeeding experiences of refugee mothers accessing and utilizing healthcare services in Saskatchewan, Canada. Dr. Sheila Harani and her team acknowledge the support of Jim Pattison Children's Hospital Foundation that funded this study. I am a refugee mother with a young child who is accessing and utilizing healthcare services in Saskatchewan, Canada. Let me share my journey and challenges that I face as a breastfeeding mother. The journey from home to hospital is not easy. I wish there were childcare support or babysitting facilities in my community or hospital. It is challenging to access healthcare settings. I don't have my own transportation, so I have to call an ambulance whenever I need it. Use of ambulance service requires a lot of time and money. In a healthcare setting, most of the time people don't understand my language. It is very frustrating for me. I appreciate the support of nurses and doctors, but I wish they were more interpreters so I can explain my healthcare needs more clearly. I wish in the healthcare setting there is no racism. The stress of racism affects my health and well-being. During the time of my hospitalization, I wish hospital had some culturally appropriate food for me. In the healthcare setting, many barriers are not supportive of my breastfeeding practices. I don't have much breastfeeding support from my social network. In healthcare settings, I often don't receive need-based breastfeeding education and guidance in my language. Instead of breastfeeding counseling, I often receive formula samples in the healthcare settings. Many a times my breastfeeding practices are not supported. In healthcare settings, many a times there is no privacy to breastfeed. I feel very uncomfortable breastfeeding in front of many people. I wish there was a breastfeeding room in the healthcare settings. Before COVID-19, nurses used to visit me at my home, but not anymore. This is my story, and I am not alone in this journey. There are a lot of refugee mothers who face similar barriers. We need your support to sustain our breastfeeding practices.
So with that video, I'd like to share that these are the references that I use in my today's presentation. I would like to acknowledge my research team, my funding from Jim Pattison Children's Hospital Foundation, and all our collaborators. Here are my contact details in case if you have any question, you are most welcome to write to me at my email address. Thank you so much for your attentive listening. Now the floor is open for questions. Thank you.
Thank you very much, Dr. Harani. If there is a quick question, we probably can take one. I know that our time is quickly passing here, but if anybody has a question, I think I don't see any in the chat box. Just maybe one question that I have quickly is there any initiative, or has there been any movement forward in establishing a doula or a birth assistant program for those that are refugees, especially in regards to language? And I know that we just had in an earlier session heard about Indigenous culturally appropriate birth assistance, and that was so beneficial. And I'm just wondering if there's some movement afoot for the same here in Saskatchewan.
So unfortunately not yet, but so far, like from our interviews, we came to know that social support, even from their family members and even from the other refugee mothers who may not be their close family member, but a friend, they are assisting each other in their journey. And many times they are trying to be the birth attendant or like kind of a support person for each other during the time of delivery. But unfortunately, with the COVID restriction in hospital, like when nobody was allowed with the mother and many mothers actually delivered at that time period was really very like causing the mental disturbance for many mothers. And they were really acknowledging that I wish I had my friend, my sister, my mother around who could actually be a support for me and can help me in that painful situation, but unfortunately not yet. We really wish if something could be an initiative for Doulas Association in Saskatchewan, or from lactation perspective, if something could be done. But definitely their family members at this point in time are the biggest support for them.
Yeah, just another symptom of our COVID, of the pandemic, and how it's negatively affected so many in the healthcare system. Thank you so much, Dr. Harani, for sharing your research with us. It certainly does help us to understand the programs and policies that really affect the health and well-being of our marginalized and vulnerable people. As our session is drawing to close, I'd like to thank all our speakers for their involvement in our showcase. It's really inspiring to hear about the research in our province, which engages patient partners as active team members. We will be having a brief 10-minute break, which will be followed by the showcase closing and awards presentation. So please go grab a drink, take a stretch break, and we'll see you at the closing session at 11:10. And don't forget, you need to go to the sessions in your menu to actually attend that closing. So thank you, and we'll see you shortly. Bye-bye.